Okay. So let's see here. There we go. And we have three speakers tonight, myself, David Cognetti, and two of my partners, Joseph Curry and Gerson Nyquist. We're going to be talking about COVID, the impact that we've had here on our department.
Join the meeting.
Lots of things that you guys are facing out there as well, so applicable to your practices. And we decided to have one topic that we're going to dig a little deeper in tonight, something that we have particular experience with at Jefferson, and that is telemedicine, which obviously has become very important as we face this problem. I really want to highlight something as we get this started, and that's today's date. And I do that for two reasons. Number one is that the information and practices are rapidly evolving around the response to COVID-19.
Join the meeting.
And so if somebody listens to this on record at a later date, some of the information, even days from now, might be different in terms of what we're doing and what agencies such as the CDC are recommending. Number two, I think it's a particularly important date. We're going to share some numbers about the COVID incidence now, but today, and reported this evening, the United States became the country in with the highest number of cases in the world. So that was just today. So this is a particularly timely topic. Of course, we ask that you all please mute your phones and microphones on your computers. I have the ability to do that, and I will do so occasionally. We do welcome questions. We ask, because of the large size of the group, that you do it by submitting it in the chat forum. We'll have somebody watching the chat, and we'll try to answer your questions, if not along the way, certainly at the end. You could give us ideas for topics to dive a little deeper into in future talks. All right, so here you can see sort of a broad overview of our department led by our chair, Dr. Keene. We're now in 7 outpatient offices. We have a huge number of faculty that you can see in these different specialties. Some of us do more than one in terms of subgrouping there. We have staff in different offices to manage. So as I'm sure many of you are dealing with, what to do when things have slowed down, how do you manage your staff, how do you keep people working, how do you pay them, etc. We are dealing with all of those issues on a grand scale. So we thought about different things that would be worth discussing. Lots of things are running through your heads. You can see this word cloud here with the social distancing and school closures and all sorts of things that are affecting our personal lives. And then, of course, things that are affecting our professional lives as well, PPEs and N95s. And you know, we want to give a broad overview of the impact this is having on otolaryngologists. And then you can see in the big letters in the middle, we're going to talk about telemedicine in a slightly deeper dive. You guys have all been watching the news. This is impacting us all. So you probably have the background on COVID-19. It's a coronavirus. So coronaviruses are a group of viruses that are known to cause disease in mammals and birds. The problem is when they jump from animals to humans, which is presumed to be the case with this one. It can cause a viral spike. Here are the symptoms at the bottom. It can be asymptomatic in the beginning, which is one of the difficulties with the spread now, with an incubation period of 5 to 7 days. If you think back to when we first started hearing about this, there were lots of things that we may have even said ourselves that have become myths, and I want you to think about these. People like to say it's just a bad cold or flu. Why are we getting so worked up about this? It's clear now that there is a range of severity of this disease that leads all the way to death, and one of the biggest issues is the ARDS and the ventilation needs of mass amounts of people. The second one that we hear is that it kills old people, and it only kills old people. That's also not true. as we're seeing even in our communities now, young people are getting very sick with this, and there are reports of young people, even children, dying of this. What's very different than the flu, if you think about the healthcare profession, is that 99.9% probably of healthcare workers are immunized to the flu, whereas really there's no natural immunity to this. It's a novel coronavirus, which is why it's so dangerous even to healthcare workers. So that's a big difference. And the last one is it won't affect me. I just talked about the vaccination issue, but it's also affecting all of us in our daily work and now personal lives, as there's been a disruption in just about everything that we do with social distancing and not quite lockdowns, but pretty close. This isn't the first novel coronavirus that the world has seen. If you look back, you've heard terms like SARS and MERS. So SARS is severe acute respiratory syndrome. MERS is Middle East respiratory syndrome. These had higher fatality rates, which might have even helped them be contained quicker. One of the problems with this virus, good and bad, is it has a lower mortality rate, but it can hang on and be of low or no symptoms, and therefore it has a high spread rate. You can see some of the numbers there on the right, that even though the mortality rate is low, the number of cases and fatalities are very high compared to these other coronaviruses. This is a timeline of progression here. I'm trying to move the videos. So you can see so this is a 2019 virus. That's how you get the name COVID-19. The World Health Organization was first alerted about the cases in Wuhan at the end of December. Things have sort of gone along since then. The first case in the United States was January 21st. That was in a patient who had traveled to Wuhan. It was declared a public health emergency on January 31st. And then obviously the month of March has been a very active one for this virus, with the World Health Organization declaring it a pandemic on March 20th. If you look at just our state, or the state of Pennsylvania, for those of you in New Jersey, so March 6th, Tom Wolfe reported the first 2 cases of COVID in our area. March 12th is when the NBA suspended its season. March 13th is when the Pennsylvania schools decided to close for 10 days. And then you can see just progressively increasing the number of cases, as well as increasing the number of shutdowns, with a statewide school shutdown being declared just this week, as well as a stay-at-home order for Philadelphia by Mayor Kenney. This is a graph. This is remarkable. We try to be as timely as possible. So this is the last time this was updated was at 8:30 this morning. So March 26th, and you can see that the number of confirmed cases in the United States was reported as 69,000. That number is now in the mid 80,000, 82, 85,000, somewhere around there, now outnumbering China as the #1 country in the world. Here is a graph
Join the meeting
showing the different countries and the timelines. And if you look and you pay attention, you can see that the United States in red here is still on an upward trajectory. This is a log scale, where some of the other countries that are referenced often, including China and South Korea, have more plateaued. So you hear a lot about social distancing, and it's really interesting, the effect that it will have. And you probably have all heard the term flatten the curve. This is the New York Times article that first discussed this back in March. It actually cites one of our population health analysts here at Jefferson, who tried to emphasize the importance of this concept and why social distancing and why they were able to do so well with controlling this in the parts of China outside of Wuhan. But what's really important to pay attention to on the graph is if you take the attitude that we're all going to get it anyway and you let it just spread, there is a very high peak in terms of the number of people who get it, and you get overrun by the acute cases, and your healthcare system can't handle it. So the dotted line is the healthcare system capacity. So if you can do anything, even if you accept that the virus is going to eventually get its way around, if you can do any way to slow the transmission so that you can keep the curve blunted and within your healthcare system's capacity, you're going to do a lot better off. And one of the troubles in Italy is that they didn't keep it within their healthcare system's capacity. You've all heard stories about them having to select who gets the ventilator and who doesn't. And, you know, the case rate in Italy compared to the United States currently is about the same. We're actually now outnumbering them, but our death rate is much lower because we are likely still within our capacity. The social distancing is one of the major means of accomplishing that. It is questionable, and this is not a political discussion tonight, about how well the United States is doing with social distancing and whether or not we're actually blunting this curve as a nation. But if you think about social distancing in reverse and think about sort of social concentration, you can see why some areas are doing worse than others. So namely New York, if you, right now, fortunately, the rate of cases, we'll go over them, in Pennsylvania is well behind New York. And if you just think about the density of the population and their robust public transportation system, that has likely led heavily to their rapid spread. I have this picture of the soccer game because there's recent reports coming out. They call this Game Zero. This was a heavily attended soccer game, one of the, I guess, biggest games in their country's league in February, that was in northern Italy, in Bergamo. And the opposing team was a team from Valencia, Spain. And they've been able to track back and say that that was like an atomic bomb of the coronavirus that allowed it to spread so badly in northern Italy. So the social distancing stuff matters. So here we are in Pennsylvania. This is as of noon yesterday, I guess. We can see that there's over 1,000 cases, and we're still down in, just over 10 deaths. Of course, this will increase, but this is nothing compared to what our colleagues in northern New Jersey and New York are seeing. And the question is, how do we keep these numbers down and keep this below the curve, if you will? I think one of the reasons so many of you logged on tonight is to learn a little bit more about the impact on us as a specialty, as otolaryngologists. There's a couple things to think about here. Obviously, this is a virus. It's a respiratory virus, so it affects the upper respiratory system. And we are seeing high concentration of the virus in the areas of the body that we treat, namely the nasal cavity, nasopharynx, and the oropharynx. So based on this, it is believed, just checking the chat here, slashing. Yeah, we'll get to some of these, some good questions coming in. So based on this,
David Goldfarb.
Join the meeting.
And through direct discussions and even public reports, otolaryngologists are amongst the highest medical professionals impacted by this. So you may have heard or seen emails going around about an experience in Wuhan. I've had personal communication with otolaryngologists in Italy, and I can tell you we're truly at the front lines of this disease. And if you think about the way we conduct our physical examinations, the way we perform endoscopy, and our surgical procedures with the mucosal disruption, we are at risk for that. Something to think about going forward as we get over this and even now, if you're still seeing patients, is that the newest report is that the patients who are minimally symptomatic, one of the major symptoms is anosmia. So even if they don't have the cough or the fever or other things, anosmia can be a sign of COVID. So CMS recommendations, as you're likely all aware, in March said to limit all non-essential surgery until further notice. We need this for two reasons. Number one, everybody's anticipating a surge. So of course you see the reports and the concerns about not having enough protective equipment. So that's a major reason. And number two is, as this spreads, there's going to be more people in the community who are asymptomatic or even symptomatic with it who can spread it to other patients and to medical professionals. And now's not a good time to get sick with COVID. Last week, our academy put out a guideline statement sort of reinforcing some of the things that the CDC already said regarding elective surgery. It made some comments regarding the limit of use of topical sprays. It made a somewhat, I don't want to say controversial, but it made a statement that has caused some difficulty in some areas depending on availability of testing, but it said that surgical procedures involving the transnasal and the transoral route should only be performed after ascertaining the COVID status. Of course, routine use of protective equipment was recommended. Here's our department's response timeline. It's amazing. It's only been a month, but as reports of this started coming about, we put together a COVID leadership team, and we started meeting very quickly. It became a daily basis. We stayed in line. We were actually ahead of some of the recommendations with regards to stopping all nasal topical sprays, stopping all elective surgery. And one of the things that we did at the beginning of the week is we transitioned to a patientless office.
Dr. Shaw.
Join the meeting.
I put that in quotations because it doesn't mean we're not seeing any patients, but it means that we're trying to keep the number of patients we see down to the bare minimum. And we'll talk a little bit how we've done that. And I think it's important for this audience to understand, because the message is not that we're closed. We are fully open and we are accepting all new consultations. It's just that we're doing it in a wise manner to be able to provide timely and adequate care while also protecting the patients and our staff. I put this quote up from Charles Darwin. He said, "In the long history of humankind and animal kind too, those who learned to collaborate and improvise most effectively have prevailed." And I would say if there's any story about our department in the past month, it's been a story of collaboration and improvisation as we've reinvented the way we've done things. So here's just an example of one of the workflows. So if you're a tremendously busy office and you're used to seeing hundreds of patients a week, probably thousands, and many new patients, you can't really close your doors. But if you make the goal of having as many of your staff at home and yet still working, again, protecting jobs is something that you're probably all facing in your own practices. You have to come up with new ways of doing things. So just this workflow showing how we manage new patients. So if you were to refer us a new patient now, that patient would go through a triage system with a trained nurse practitioner or resident to directly discuss with the patient what's going on with the COVID situation, ascertain the acuity of their problem, and then filter out with the support of all of us, their attendings, of who should be brought into the office right away and who shouldn't be, and managed via telemedicine. And we are finding that we can do a lot with telemedicine, including new patients. I told you that we're going to spend a little extra focus on telemedicine. This is an area that Jefferson has had interest in for a few years. I show you this publication that we've had. I also show you a mini seminar that I was fortunate enough to be involved in last year at the Academy meeting. They just posted, if people are interested and members of the Academy, if you go to the Academy Q or Academy U website, this is now available for free as a highlighted offering of their educational system. So I went to it to look and see what I was even speaking about back then to compare to what we're dealing with right now. So these next couple slides where you can see the emblem from the Academy are from that presentation last year. And one of the things that I showed was Jefferson has an emphasis on innovation. So here's our president and CEO, Steve Klasko, all in the region should recognize him. But when he came to Jefferson, he sort of challenged the entire institution to be innovative. And one of the things that he pushed was telemedicine. He recognized that Philadelphia is a competitive medical environment, but more importantly, he recognized that patients don't like to travel to center city or large urban areas. And finally, from a business standpoint, he recognized that at some point, healthcare will change to value-based payments, and you won't necessarily need to churn patients through your office, and it'll be a disincentive to do so. What we didn't recognize is that a world pandemic would make telemedicine even more acutely valuable than the slow change to value-based learning. This is Judd Hollander. He's the head of our strategic health initiatives, and he's basically headed our, or he has headed our telemedicine group for years. And when I prepared for this presentation last year, one of the things that I really liked that he explained, I said, how do I teach people how to do telemedicine? He said, one thing that we often quote around our office is, it's not about the technology. It's about the workflow and the operations. And we learned that full dose this past month as we made our workflows and operations to allow us to continue our practice. And I want you to think about that as we go through this tonight. You will get some information about the technology a little bit later, but you really want to focus on how you manage the workflow of your office. And as we think about why telemedicine didn't take off until now, per se, it's because things like change management is typically difficult, and there wasn't heavy reimbursement for it. A couple more slides highlighting advantages at the time and the challenges. And the challenges that people faced were, you have a limited examination, you can't really cross state lines legally, there's questionable liability, and the billing wasn't clear. A lot of people weren't paying for it. And I highlight these slides because just in the past couple weeks, in response to the COVID epidemic or pandemic, there's been a heavy response by CMS and private insurers to change these things, which have been hurdles for the adoption of telemedicine. So things like state lines and billing have changed and are constantly changing to make telemedicine easier to do. So if you want to have somebody do something, right, you can either force them to do it or you can incentivize them to do it. And I think COVID-19 is doing both of those things for the telemedicine evolution in our practices. Because quite frankly, right now, many of you probably have closed practices or close to closed practices, and you're going to need to adapt to be able to continue to service your patients and survive. These are just some numbers showing what we're doing with telemedicine now this year compared to last year. This is just for the month of March, and you can see the first month of March, the concern for the COVID-19 hadn't really hit. Second month of March, all right, it's coming on. And the third third week of March is where we went to the near patientless office. And you can see the year over year numbers increasing by 1,000%. We expect to need to do this going forward, potentially for some time. A lot of people ask, how long is this going to last? And they try to compare to China and Italy and other experiences and try to guess when we'll be back to normal. But, if you really think about it, I don't think we're ever going to get back to normal, whatever you want to define normal as. I think this is going to change the way we do things permanently, and we're going to have a new normal. And it's unclear how much this will impact us, both with the size of the peak, right? If we have a huge surge, we will not be doing elective surgery and other things. But not just the peak, what's the tail going to look like? How long is this going to drag out, even at a lower rate? And how long will it take us to dig out of the backlog? And for that, we think telemedicine is important. So that's the end of my presentation at this point. I'm going to hand it over to Joe Curry now, and he's going to talk a little bit more in depth about some further issues.
Okay, cool. So, I mean, the biggest thing that motivated us to do this tonight was to try to reach out to you guys to see if you were able to move over to telehealth. We've really pushed, as Dave highlighted, through the leadership in the department, to move as much as possible towards telehealth in order to compensate. And I think for a lot of practices, losing the volume is a huge strain, and in many cases, it's resulting in layoffs of staff and needing to compensate in a lot of different ways that are financially painful, resulting in what's hurting the economy right now. And so what we were hoping to do was reach out to see if there was anything we could do to help you guys enact as much telehealth as possible, since that looks like, at least for the time being, the only way that we're really going to be able to keep in touch with our patients, keep our finger on the pulse of what's happening with them, ensure that they don't get disconnected from care, and then also to keep things moving so that we can stay open and keep going forward. So in order to provide patients access, the government has actually taken down a lot of the barriers to telehealth over the past few weeks. As you know, there were previous restrictions on where you could do telehealth. Now you can pretty much do it anywhere in the country. We have the good fortune of being completely connected through Epic using Haiku or the other apps for the phone or the iPad. So that allows us to use Epic directly for telehealth. But many of you may have an EMR or may not, and don't necessarily have access, or have had it partly started, and so it may not be fully functional. Fortunately, one of the barriers that the government has taken down is actually the number of types of applications that you can use. The restrictions are mainly there to protect the patient in terms of HIPAA, to protect their information. But right now, you can use FaceTime, you can use WhatsApp. And I think if you don't have an EMR that has connection like Epic, there's a website that I think a lot of people are using called doxy.me, which is actually very easy to set up. You can set up an account pretty quickly. The patient doesn't need to download an app. I think, I don't know if Chip is on the line, but Chip Morrow and Zubair Syed are starting to use this as well. And I think they've had a lot of great success with that, getting that off the ground very quickly. There are some platforms that you can't use, but I think if you have access to these are all very easy ways to move forward. The issue with just calling them on FaceTime is that they would have your cell phone number. I think our guys are working on trying to figure out ways to create a dummy account. When we get that information, if we get that working, we can let you know that. But I think really the best way to go, maybe if you don't have anything, is doxy.me. Some of the keys to telemedicine Previously, it really had to be restricted sites. You had to be an approved site. The distant site is where the provider is. The originating site is where the patient is. And so you had to have approval previously, but that's actually been relaxed significantly. So pretty much if you're any doctor, you can access your patient. The main key about telemedicine is that it has to be synchronous. You have to be looking at the patient on the device and interacting with the patient in real time on the device to bill a telehealth visit. There are some other increasing or some other restrictions that were decreased. There are codes that are now open to multiple providers. So if you have a nurse practitioner or a PA in your practice, there are codes that they can bill as well. And then also, as I mentioned with HIPAA, the patient does need to provide consent for telehealth services. So Gerson's going to talk a little bit more about the note, and I think Kyle's on. We could have him comment if people have questions about some of the specifics on how to get to a certain level of visit. He might be able to help us with that as well. But one of the things that's key that we put in our note is consent for digital health services. This implies that they understand they're interacting with you on an electronic device, and they understand that there may be some risk to their privacy. Okay, so the codes that you can use are actually visit codes. There are a number of different codes that are available, but you would basically bill like an established patient visit, or now with the relaxed codes, with the relaxed regulations, you can bill a new patient visit. Now, of course, your exam is going to be limited, and so it's much harder to get to a higher level new patient visit, but with the proper documentation, and if it's an acute visit, you can actually get to a higher level visit for an established patient. Okay, so there are some modifiers that are used for telehealth. The 95 modifier is the telehealth modifier, and some private insurers were not paying that. There are probably still some holdouts, but as you know, there's a dictum to expand that. So we're likely to see much increased coverage of telehealth visits. There are a number of other modifiers and codes that can be used for some of the other types of coding and other types of electronic interactions that you can do. But I think the biggest thing to know is that some of those other visits are lower reimbursement visits, whereas billing for an office visit is going to be the best way to go ahead. All right, and so the other types of codes that I mentioned are these digital check-in visits. There's a variety of them. If you see the top three, 99421 through 99423, these are essentially like telephone calls. You have the telephone visits. I'll show the codes for those a little bit later. That's when you just call someone up, you check in with them, you review a result. There are some restrictions on those. They're not supposed to be associated with a visit that you just had. So if you coded a visit for a neck mass and you're calling to follow up where that neck mass within 7 days of that visit, then you can't bill under that code. Now, if you bill under a different code, you can actually get reimbursed for that if there's something else that you're calling them about, or a different instance that you're calling them about. There are codes for non-physician professionals. Those are the bottom three. So if your nurse practitioner calls a patient back about a result, those are billing instances as well. With a digital check-in compared to a telephone check-in, you're actually interacting with the patient. So this is, again, you use Doxy.me or use Epic or use some other interaction, some other digital interaction that allows you to talk to that patient and see the patient. And so these are the telephone codes. And we all know these are lower reimbursing codes, of course. The 99441 is about $12 or $13. This is the 42 is about $25, and this is about $35, $38. But look, I mean, we think the bottom line is right now, if it helps you keep your staff employed, whatever means you can use to contact your patients, connect with them, and keep your practice running. If a patient can't connect, many patients don't have smartphones or don't have a webcam-enabled computer. This allows you to keep in touch with them and allows you to provide a service to them as well. All right. And I think when you do this, the documentation is important as well. Gerson will talk a little bit more about the notes, but even if you're doing one of these digital check-ins or telephone check-in, you do have to detail in your documentation the type of care that you provided and how long that justifies your billing level and the plan that resulted from that documentation or from that interaction. All right, and then just so you know, if you have a speech pathologist or if you have a therapist in your office as well, there are codes that they can bill. Similarly, they can bill over the phone or through an electronic interaction as well. It's not just for the explicit medical care that you or your nurse practitioner or your PA provides. Your supplemental providers can also bill as well. So there's a way to keep them working, whether it's from home or in the office, in a basically patient-free or patient-less office, as Dave talked about. And then these are just a few of those other codes. I think we can get into that maybe more in detail. If you guys are interested in that, you can post any questions about the coding, and we can talk about that at a subsequent WebEx or meeting. With that, I'll turn it over to Gerson, who's going to go over a little bit more of the detail on the notes and what we're putting into the notes to justify the level that we are coding currently.
Thanks, Joe. So one of the big questions was, can we see new patient visits? And if so, how do we bill for them? So not only did CMS encourage new patient visits via telemedicine, but you can also do hospital consults. And that's really to limit your exposure and patient exposure while they're in the hospital. So these codes are for any new patient, whether in the hospital or in an outpatient setting. So just to review, go back, new patient. You can really bill E&M codes either by time or key components. So if you bill by time, you just have to be careful to document as you would for a normal visit in your office that greater than 50% of the time was spent counseling or coordinating care, such as how to do nasal rinses, how to take care of a wound, how to use medications, and you just need to be able to document that it was spent counseling and coordinating care. Otherwise, you can document by key components, and that's the history, physical exam, and medical decision-making. When you're seeing a new patient, that requires all three, the history, physical exam, and medical decision-making. So if you're going to use the key components to bill your E&M code, the highest that you can really get is to a level 3, because a comprehensive physical exam is not really possible via telemedicine, and we'll go into that in a few slides, because you can't really physically examine some parts of the body and get to the level of complexity that's required, either with a subspecialty exam like the need to visualize the larynx, or with a comprehensive exam of the entire body. So if you're going to use the key component exam to use for your billing, the highest level code that you can get to is a level 3. If you're going to use time, then you just need to document the amount of time and that you spent greater than 50% counseling and coordinating care. So what about the established patient? Again, the E&M codes are here. You can either bill based on time or the key components. If you're going to base on time, it's the same things I just discussed, which is basically you have to document greater than 50% of the time is with coordinating or counseling and the care. If you do it via key components, only 2 of the 3 are required. So you do not need possibly the physical exam in order to get your level of service. So if you use history and medical decision-making, that's all you really need. You don't need a comprehensive physical exam to get to some of the higher level of visits. So with a telemedicine visit for your history, if you're going to use a comprehensive history, just remember, like you would for seeing a normal patient in the office, you either need to have a chief complaint and an HPI or 3 chronic problems. You need to get a 10-point review of systems, and we've often used our nurses to screen the patient, let them know that we're ready, and take a history and obtain a review of systems, and they document that in the chart for us on the telemedicine visit. You also need the past medical history of medications, family history, and social history. So just like you were seeing a patient in the office, the more detailed of a level you're trying to get to, or the more detailed of an exam you take, the more documentation is required. So what about the physical exam? That was strange. How do we document a physical exam via telemedicine? Well, when we looked at that, you're really looking for the inspection and assessment, not the examination. So I gave an example of what we use. So if you're able to inspect something such as what does the face look like, how is their mentation, looking at the skin, the range of motion of the neck, how are they breathing, these are things that you can all do within compliance for your detailed physical exam. Again, you can't get up to a comprehensive exam, and we're looking for inspection and assessment, not examination. we do document that this is limited by the telehealth monitor, just for coverage purposes, that the patient consented to the telemedicine visit. And we also document that this telemedicine visit was spurred in response to the COVID-19. And that also helps for some insurances that are having coverage only if you document COVID-19 discussion. So most are covering any telemedicine visit. Some insurances, such as Humana, United, and a few others, want you to document it's because of COVID-19. That's it, Dave.
Thanks, Kirsten. And thank you, Joe, as well, for great presentations. I'm sitting here thinking about the paper.
Let me add one thing, Dave. Sorry.
Yeah, sure.
Right now, one of the other regulations that was waived, I forgot to mention, is that you are allowed to waive copays, or copays can be waived, which was previously not allowed. So, like, if, for example, if you're worried about it, that's one of the things we worried about at first, was like, our patient's going to be upset that they get a bill for a visit. And in reality, what we found is, for most of our patients, they were happy to save the travel time. They were happy to save the parking time. And in general, most copays were covered. When they weren't, occasionally we'd have an issue, but it's very rare. And I think in a setting like this, you're providing a really valuable service. And I think that if you're worried about it, you're allowed to waive the copay. But it's just one of the new regulations I wanted to mention.
Yeah, so it's interesting, Joe, you referenced that. I was thinking back to our initial experience with telemedicine, which we put into that paper that we published. And what we found was patients saved over 3 hours of time. They saved copays and parking and that type of stuff. And we were pretty much limiting our telemedicine visits to relatively simple post-op patients who would fit into the global period anyway, because we really weren't sure how the billing would work. And now you go through a world pandemic, we are sending, because we're not doing elective surgery, we're doing only complex head and neck surgery, and we're doing everything we can to not see those patients in the office, absorbable suture, et cetera, et cetera. And we're the only ones we're seeing in the office are probably the complex new patients and urgent visits. So it's been a real turnaround, sort of forced adoption, if you will. And it just speaks to the power of using this. So I'm going to look at the chat now and open that up. We have an email here. Of course, you could reach out to us directly as well. But we would love to hear feedback on other topics that you would like us to do in a little bit more detail. We'll try to answer chat questions now, but we recognize we'll run out of time to cover all things COVID, as this is a very robust topic. So we'll start from the most recent and work back. Does the coordination of care need to be face-to-face with doctor-patient for timing and level of the visit? I don't know if Joe or Kirsten, you want to take that one?
Yeah, the coordination of care, that would include the counseling. So you would, if you spent 50% of your time or more coordinating care or counseling, then that would allow you to bill via time and not otherwise. So
there are other questions here that reference PPE, specifically PAPRs and tracheotomy. These are big topics that we're still actively discussing and working through with our command center and then within our department. We could probably have a whole nother discussion based on that. I'll try to give you a little insight to the specific questions here. One is, can you share exactly what resources Jefferson uses for physician and staff safety when using PAPRs? So I guess you have to ask when you're using them, but certainly for us, the instructed use of a PAPR is to have an observer don and doff you. Both should be familiar with the process. Jefferson has a video for the staff to watch. We had an instructional time at one of our departmental conferences, and it makes sense if you're wearing this big device to go into a room that has a COVID positive patient and you're wearing a shield on your face that would get hit with droplets or airborne virus, you don't want to walk out of the room and then take it off the wrong way and put your hands on it. So it's a process, including wiping down the mask with the help of another while it's still on you. Can you explain the protocol for hospital consults? So we're an academic center with residents. We have significantly restricted our residents' exposure to patients. They are not in our clinics. They are at a minimum in our ORs, meaning only the number of residents that's absolutely needed. So we'll do cases without residents. We'll do cases with one resident. And for consults, they are not to physically see a patient without us deeming it necessary. And I think that's a protocol that can be had in any practice, including community practices, where you have direct discussion with the person consulting you of whether or not the consult is justified given the times and the potential exposure risk. And people get it. The consults have gone down to our service because just as we're instructed to not see these patients or instructing our residents, the other side is instructed to only consult when absolutely necessary. There's another question here about tracheotomy in negative pressure OR. I would state that's probably assuming that that patient is COVID positive. We are having active debate and discussion about doing a COVID test on all patients who require tracheotomy. And that is something that we advocate because of not only the OR exposure, but the potential of a tracheotomized patient being a super spreader thereafter. So we advocate for that. We're working through that at our institution. If you're talking about a situation where you have a COVID positive ICU patient, fortunately, we are not at that point in the curve at Jefferson yet because, and hopefully we won't be, because we have a low census of COVID right now. But there are lots of discussions about how long you wait, and you do wait longer. And the international experience suggests that many of these patients will not require tracheotomy because they will either be extubated or unfortunately some will pass. So the advice there would be to delay as necessary and assess their course. If you do decide to do it, then the recommendation would be PAPR, preferably in a negative pressure room. And so you'll have to know where those exist in your hospital. Jefferson has negative pressure ICUs. We don't have negative pressure ORs. Besides the fact that you don't want to transport these patients unnecessarily anyway, it's best to do it at the bedside in the OR. Do you think we will have to use PAPR for nasal cases moving forward? Ideally, no. That's really difficult. The implications we're learning as we try to use PAPRs is that it goes beyond just the surgeon. You have to worry about everybody in the room. You have to worry, are you in a negative pressure room? So if you're declaring the case needs a PAPR, there's lots of implications that go along with that, including the anesthesia machine. The ideal case, if we ever get back, the point of discussing this for elective surgery is that these patients would have testing and that we would know with reliability what we're dealing with before we go in. I think, Joe, I guess you answered that one. Yeah, nosebleeds are of particular concern to our specialty because nosebleeds are an issue where, I don't know if people are following the chat. So for those on the phone, it's what's the PPE protocol at Jefferson for managing simple matters in the ED, such as nosebleeds or peritonsillar abscesses. For epistaxis, we've made the declaration that that's a high-risk procedure because of the risk of spray of blood during management of it. So we do favor PAPRs for that situation.
Yeah, just to add on.
Go ahead, Mark. Yeah.
Nosebleeds, we've kind of made the recommendation that if somebody comes in with a nosebleed, obviously you may not be able to get a PAPR that quickly, that no attempt at trying to stop the bleeding, just to put a pack in and get it under control as quickly as possible, and then regroup and decide how you're going to manage packing removal and further treatment of the epistaxis. But we've told residents in ER just not to try and cauterize, not to try and control the bleeding, just throw a pack in. And then, as I said, in the once there's a pack in there, they're difficult to test for COVID, so we have been using PAPRs for packing removal control of epistaxis after they've already been packed.
Lots of questions here. All right. Should we trach all COVID-19 positive in the ICU? We talked about that earlier. Preferably avoid transport and stay in negative pressure. More PET CT scans during workup prior to referral to Jefferson. Sure, but as I said, we can handle a lot of this even via telemedicine. One of you sent a patient down, a woman in her 80s with a lateral tongue cancer. I saw as a new patient today on telemedicine, coordinating scans, and we may even be able to coordinate that I meet her on OR day because her situation is relatively straightforward from an examination standpoint. So yes, testing helps, but we can still help manage. Are ortho suits as good as PAPRs? Can ENT use PAPR and OR staff use ortho suits? Paul, that stuff's being actively discussed. Any full head covering is good for sort of droplet and spray. Obviously, some of the covers, if it's not attached to a powered air purifier, it would not have the HEPA filter and what you would need. So I don't know that ortho suits are a full equivalent. Do you have access to rapid COVID testing to determine COVID status? We do, Don, as of this week. There's many discussions about how to prioritize it and whether or not asymptomatic pre-surgical patients are appropriate. We're all aware of the Stanford protocol and even the Academy guidelines. And that's why without qualifiers on those guidelines and recommendations, it does make it a little bit difficult for, different locations to manage those recommendations with regards to the current incidence of COVID and availability of testing. We're working through it. Our departmental recommendation is to be in line with the Academy for mucosal cases. And we have delayed some cases to allow us to do that. Where are we with the Chinese are doing? Yeah. Yes. So there's a lot of interest in tighter IgM testing, IgG testing. My understanding is there are a few hospitals who are starting to get those things on board, and they're starting to do validation testing even at Jefferson, but they're simply not available for clinical use right now. And then the last one I see here is percutaneous versus open trach. I had that conversation actually, I believe today or yesterday with a ICU colleague or somebody else. Look, I'm not sure that it's a big enough difference in terms of risk to the people in the room if you're wearing proper PPE. What concerns me, so myself and our group at Jefferson, we do not perform percutaneous trach, and I don't think that on a high-risk airborne case is a good time to either go through a learning curve or deviate from your standard. So we will do open trach for these cases, and I think everybody should do what they're doing most frequently and not trying to learn new things on high-risk patients.
Hey, David, I would just also mention that I think there's probably this is Richard Goldman, by the way. There's a variety of other technical considerations that you need to consider when doing trachs on a positive patient or person under investigation. We could try to get some guidance out on that. But, little things with respect to differences in doing it in the unit, how to hold ventilation and make use paralysis and things like that to minimize the risk to personnel during the points in the procedure where there's not a definitive airway in place.
Yeah. And the final question, we'll just make this the final question because we're at 9:29, is patient blood thinners, rhino rocket, epistaxis is in the ER. Do they have to be admitted to the OR to be removed with PAPRs? I would say that the OR is not the only place you need to use a PAPR, although PAPR would be the recommendation. So, and sometimes, quite frankly, if you can have a negative pressure room in the ER or some other location, that's probably better than taking the patient to the operating room. So thank you. What a great turnout. We're thrilled that we thought about this yesterday and we had well over 70 attendees today. If you can fill out, we just shared in the chat box a link to a form for responses that if you can tell us how we did, and more importantly, help guide future discussions, we'd be very happy to do this again in the ensuing even days, not weeks, if there are topics that we can share information with you. Of course, we're all available. If somebody doesn't have our cell phones and contacts, just reach out. We're happy to share. We are still available for consults during this time, and we will help guide you through the care of your patients. Thank you, everybody.